Welcome to Constant Curiosity, a trauma-informed podcast. My name is Dr. Caelan Soma, and I am one of a few different hosts for our new series. Our guest, Dr. Summer Liston-Crandall, is the Chief Medical Officer for Oaklawn. Dr. Liston earned her bachelor's degree from Harvard and Radcliffe Universities and her medical degree from the University of Michigan. She completed her family practice residency at Oregon Health and Sciences University in Portland, Oregon, and joined Oaklawn as part of the active medical staff in July of 2007. Since 2021, she has served in her current role as Chief Medical Officer. Welcome, Dr. Liston. It is an honor to have you here with us today.
Thank you for having me.
One of the key tenets of trauma-informed care is really the need to remain curious. When we are working with individuals who have experienced toxic stress and trauma, we can't assume what it has been like for them. We have to remain curious about what's happening in their bodies, in their relationships, in their lives as a result of what has happened or as a result of what continues to happen. So we also have to be curious about, what worries them most and what supports do they think they need the most as we begin working with them. So tell me, what have you been curious about lately?
It's such a great question. And, in the context of this conversation, I've been curious about what is hurting our children. Like, why are our children feeling the pain of depression, anxiety, loneliness? Like, what can we do to support them? And how do we move forward from here?
Yes, absolutely. That's a big question.
It really is.
In light of the national, declaration of the crisis in childhood and adolescent mental health, we all have to be curious about what is going on, what's really driving those symptoms and the reactions that we're seeing in our kids.
Yes.
So, Summer, as you are curious about that, do you have any assumptions you could make about what you think is happening? Why are we seeing the anxiety and the depression we're seeing in our kids?
I think it's a compilation of all that they've been through, whether it's routine stresses of forces like poverty, family separation, food insecurity, but then you pile on this giant pandemic and the impacts that it's had on our kids. And I think it's really no wonder that they're suffering.
And what are you seeing when you're presented with a patient, a child who you're curious about because they're presenting with some symptomology? What are you seeing just in their bodies? What's happening just in the way they present?
It can be so many different things. So, I can picture I think he's nearly 8-year-old who is hiding behind the exam table like he was a 2 or 3-year-old and wouldn't speak with me. In fact, I just saw him out and about, maybe Sam's Club, just out shopping, and he still didn't want to make eye contact with me. He could, it was uncomfortable. And so what has made him, I don't see myself as a threatening person, and as a mom, I'm used to that age group, but he definitely felt the need to hide, and that felt unusual and like there was something more.
Right. So a child of that age who's hiding means that maybe they're worried or they're scared.
Right.
They're fearful of something.
For sure.
And what we know about trauma is that in the course of development, if you have too much stress or too much of a stress load that's ongoing during that development, we're seeing that kids kind of get stuck at stages that are much younger than what their chronological age really is. So do you think that it's just part of the development hasn't happened as it should?
It seems like it. I think it may be an example of a child whose development was halted by circumstance, whether that was being pulled from school as he was a kindergartner, having school from home. Meanwhile, his parents actually have divorced during the same time, and whether he just could not proceed into a normal developmental stage where he would engage with me in a sort of normal, playful way.
So as caring professionals, let's say as parents or teachers or as a physician, if you weren't taking the stress into consideration, it would be really easy for you to think something's wrong,
right?
Or to get really frustrated, let's say with the behavior or with the fact that he isn't where, let's say, your older children are, who didn't have those same experiences. How do you talk to parents about that?
I think it's a really important thing to tackle because, you have a child hiding. You might have a sibling sort of teasing him about hiding.
Yes.
You have mom who's sort of been trying to reckon with his behaviors and keep him on track. But asking the question about, where is dad? Have you guys seen him lately? Or what are the plans? How is this behavior at school? Like, is this something that his teachers are seeing also? Or is it just here where he's less comfortable because he sees me, only every few months? I think that trying to phrase important questions about the support that they have outside of, just the nucleus that I'm seeing, whether grandparents are involved or the teachers are going above and beyond to support him. I think that we've got a lot of important things to draw upon.
So what are some other curious questions or things that you can explore with a patient if you have this feeling that something may be impacting the symptoms and reactions that you're seeing?
I think just asking it in a I'm not trying to be rude kind of way, but has he seen, violence? Has he had his earth, sort of rocked by other circumstances? Almost using our ACE or Adverse Childhood, Events questionnaire in sort of a casual way, but asking those questions and delving into what's impacting him.
Okay. And I know sometimes what I like to say is something like kind of normalized, right? Like, gosh, a lot of kids that I work with who have had bad, sad, or scary things happen to them often have a hard time managing their emotions or being able to, sleep in their bed all night just by themselves, or go back to behaviors like sucking their thumb or wetting their bed, having difficulty in school, and sort of connect the behavior to the fact that these things might be happening because of the stress, right? And not just for the parent, for that education piece to kind of make them feel like you're not doing a bad job. It's this something really is interfering with this child's ability to regulate, but also helping that child know that other kids have those experiences too. And I'm sure you see it in case after case after case. Do you have another example besides the kind of like the hiding? Like, that's such a I'm trying to keep myself safe, so I'm going to kind of hide a little bit. What else do you see that would make you kind of curious that maybe something was going on?
I think there's sort of age inappropriate tantrum type behaviors where you have, again, children who aren't 2, they might be 4 or 5, just totally losing it. And not because we're going to give them a shot, which is of course frightening. I sort of excuse that because that's a direct physical threat. But just to, even getting weighed, like how is getting on the scale, having to leave, let go of mom's hand for a moment and getting on the scale and getting a height, how is that a threatening behavior? Just last week I had a child, kind of screaming and crying about that event in the hallway.
Wow. Before
I even got to the room to check, ears and throat and stuff that, and who knows, really, was that just being fearful or was there something else at play?
Yeah. So when we think about, it's such an interesting perspective, because if we think about what might make you curious, it's something that's outside or something that you're observing that's outside of sort of this normal zone of regulation, right? Or this normal zone of tolerance in which, okay, the child should be fine with the scale. The child should be fine with, looking at the eye chart. Sure. I know they're going to be upset when I tell them they have to get a shot today, right? So it's like assessing what is out of that norm, right? And can you tell right away if a child is dysregulated when you enter the exam room?
There's a first impression, certainly, that comes with it. Either almost a hyperactivity, and outside of normal, like cooped up 4-year-old hyperactivity, but just a bouncing off the walls, unable to settle kind of dysregulation. I see that. Or it can be just nerves. Like, as sort of an empathetic person, you can walk in the room and feel the nerves from someone. And I've seen a lot of that.
So not just the normal, I'm here for the doctor to look in my ears, eyes, nose, but oh my gosh, I'm really buzzing, that anxiety.
It seems like it almost builds, and I know that we know this about trauma, but I'll have parents say, yeah, this has been her response ever since she went to the dentist or ever since she had her eyes checked. Like that there's something about a medical environment that has now spurred this sort of traumatic experience within medicine. And then we have to take responsibility for having given shots and, doing other things like that. And all of those things are heightened, it feels.
Absolutely. So you've got to differentiate between just the normal, what do we call it, white coat syndrome, versus all the other stuff that is impacting this child in terms of feeling dysregulated. Yes. Can you see it in the parents too? Do you pick up on that?
Oh, sure. They feel harried. They feel overwhelmed. When a parent is both yelling at their child and texting at the same time, they're not giving the sort of appropriate attention to the child and the child's needs. I think that we see a lot of distracted parents and overwhelmed ones.
Yeah, that makes me think of something. So when we're thinking about kids who have experienced stress and trauma, and we're thinking about how dysregulated they are, and how frustrating that can be for parents and for teachers and babysitters and grandmas and grandpas and healthcare providers, we go back to, okay, they're dysregulated, so what do they need most, right? And it's not more discipline or fear or to get in trouble. And the same thing with the parent. They really need help getting regulated. So how do you help a child and a parent regulate in your exam room, given everything that's going on? Is it you keep your own body language in check?
I think one of the first things I'll do is I won't approach the child who's fearful or the child who's withdrawn from me. I will target all of my attention to the parent. So I will speak most to the parent, angle my body even away from the child for a while until I can then introduce the idea of me engaging with them. So I'll speak with the parent and then try to engage with the child a little more calm. This is an example of if I act uptight, much like when if I parent as an uptight parent, my kids feel that. And so if I doctor like an uptight doctor, the patients feel that. So I have to almost get extra calm and extra easygoing as I face that.
It's brilliant that you do that with the parent first, because what then you're able to do is, okay, I've got an anxious, harried parent. First, let me get that person feeling more regulated. Right. Then the child picks up on the cue from their attachment figure to be able to say, okay, it looks like mom or dad or grandma, whoever's there with them is okay with this person. Right. If they're okay, then maybe I can feel safe.
And I also think that helps parents when I say, oh, lots of kids do this, or
normalize.
When I normalize the fact that they don't want to see me right away, the child doesn't want to see me, and it's not bad behavior, but just sort of a usual.
Yeah, like it's okay.
It's okay.
Yeah, like you don't have to talk to me at all right now. I'll talk to you in a few minutes. First, I'm going to talk to your mom or your dad for a little bit.
Yeah.
And then we'll move on. Yeah, so that whole expectation, right? So we have all these expectations of the way kids should behave without stress and trauma, right? And then we put that layer on it. So maybe the expectation is that they probably will present anxious and nervous and scared. So let's go in proactively to set this child up for success with the supports that we need to give them. And I think the main support in this case is your own nervous system and your own ability to regulate. Like you said, I'm not just calm, I have to be extra calm, right? Which means you have to keep yourself extra calm as you're knowing you have to see yourself, get into another exam room in the next 15 minutes. It's got to be hard.
And when you can see it with infants too, because, parents are very overwhelmed when their child's crying, especially when it seems like they've done everything that they can do to calm those kids. And that's an example of where I have to, again, sort of calm my physiology when I approach the child who's crying, and often just using a very calm voice and not being as harried as the parent who's been up for 4 nights straight because their child's been crying. I find that it is, and again, normalizing it, normalizing that it's okay that a child's crying. They're cold, they're uncomfortable, they're...
somebody's touching them.
Yeah, somebody's touching them. They were on the scale, it's chilly. And so I think that you can see it at infancy, you can see it in childhood, and you can see it in teens and adults as well. That just the need to present a calm and, as you said, curious approach about just people and what makes them tick.
Right. So when we talk about being trauma-informed, it's not so much this major intervention. It's more so your interaction with them that's rooted in normalizing and creating an environment that helps them feel a sense of safety or calm. Yeah, those are the two things that kind of stand out to me. Wow, that's a good one. Just reflecting on you saying, I don't only have to be calm, I have to be really calm. How do you do that? What do you do? What is it about you, or what are the strategies or skills that you have to help yourself stay regulated because it's so important for your patient, despite the fact that you have your own life too?
Right. Some days are easier than others, right? And the distractions are real. I don't have my watch on right now, but it'll be buzzing at me, and my computer will be dinging, and I get a knock on the door, saying that there's something else. So I try my very best to be with the patient, be present and all in, even if it's for a short time. And then if I have to be distracted, I'll say, excuse me, I have to handle this real quick. I'll turn to whatever it is, whether it's to my medical assistant at the door or whether it's to an urgent message on the computer. And then I'll get back to it, rather than trying to be in 2 different mental spaces at once.
Sure.
I will work my way back into the one where I'm with the patient and the parent 100%.
Yeah.
As best I can.
Is there anything you do in your life just on a day-to-day basis to sort of proactively set you up for success to stay calm?
So there's all kinds of, self-care things that I really try to engage. If I haven't eaten, had enough to drink, gotten enough sleep, and exercised, I don't regulate well. And so I snack frequently, and I take water breaks, and I do some meditation and mindfulness things, and, just working on being the best I can so that in whatever dimension I'm working, whether it's with patients, in meeting rooms, with my own children, so that I can be the best I can. It does take sort of investing in myself.
Yeah. And if you think about one of the most important things in working with children and families who are at risk and dysregulated is that you have to show up regulated. That investment in yourself just has to be such a priority. So let's say you're with a family or with a mom or a dad and a child, and you know that something is going on. How do you keep yourself calm, but then embark on broaching the topic that maybe we need to make a referral, or maybe that there's something else that needs to be addressed that isn't just a stomach ache or isn't just the headache that's showing up, or that the repeated complaints of behavior problems at school are something bigger?
I think this is where open-ended questions come in.
Okay.
And say, do you ever wonder what might be, what's underpinning Callie's pain? And so saying to the parent, do you ever notice that her headaches come on after something in particular has happened? Do you feel like stress is playing a role? That's a phrase I use often. Do you feel like stress is playing a role? And I think most everyone says yes to every, they're pretty willing to say yes to that. And then asking follow-up questions.
So that your curiosity helps to trigger their curiosity.
Yeah. Some of those I wonder questions.
I wonder. And I love that also puts you in this role of, I'm not the all-knowing doctor and I'm going to tell you what's wrong and what to do, but I am asking you to be a partner in helping me investigate what you think matters most.
I like the way you phrase that, for sure.
For this child. And what can we do from here? What if it is, something related to school? And let's be curious about that. Is there something that we can do together to make that better? And just, kind of like this partnering with them and giving them some voice, right, in the matter.
Yeah, I don't think that a traditional model where the doctor tells you what you should do and how you should think is going to get you anywhere. I agree that sitting down at someone's level, having eye-to-eye contact, and really working with them on finding solutions is a way to move forward.
Yeah, I love that. How do you begin to talk about stress in a way that makes it easier for parents and children to open up, as opposed to saying like trauma or crisis?
Yeah. So I often talk about cavemen. So I'll have, I get back to sort of evolutionary roles of what stress was back in the days where survival was based off, running away from predators and there being famine. And our bodies were built to climb a tree and stay alert and heart pounding and sort of all those fight or flight type responses.
Hide, like the little boy
hide from the bad guy,
right.
From the predator that's after you. And most of the stresses that our families face now aren't those sorts of stressors. It's typically relationship stress or other things that might be threatening, but not to that level, but yet our bodies still respond in the same way. So I described the heart pounding, inability to sleep, hyperactivity, hypervigilance that comes with that. And I think it helps to really sort through some of that.
So that makes me think of something else. You mentioned the body responses to threat or to being in survival or feeling like you have no control over your situation. Your body takes over with the heart rate, increasing, and with your respiration rate increasing, your muscles tensing, and how that often looks like other mental health disorders.
Oh, truly.
Right?
Yeah.
So how do you begin to have that conversation when a parent might say, look at him in here, you can see he's bouncing off the walls, he can't sit still, his teacher said he can't focus, he doesn't pay attention. And immediately, you're thinking what the parent is thinking. The parent is thinking, does my child have ADHD? But from working with that mom or that family that they have a lot of family or community stress.
Sure. Yeah, and I think it's important to bridge the context that we know, what the parents are going through, what the families are going through, and then bridging that with the experience of why it might feel threatening and why our bodies respond in that, again, that fight or flight kind of, hypervigilant inability to self-regulate, because that was a survival technique.
Yes. And if we were never curious about how stress was impacting bodies, we could diagnose people all day long with mental health disorders.
And with other medical illness as
Yes.
well, because we'd be saying, oh, look, there's tachycardia, meaning, high heart rate. And there's, wow, they must be short of breath. Let's do an x-ray. Let's investigate this. And we see that a lot. Plenty of patients who are suffering like this have excessive testing done.
I was going to say, how often does that happen where it's like the blood work is fine, your tests are fine, everything is showing up normal, but they continue to have these symptoms?
Yeah, it happens so commonly. And, high emergency department utilization is expensive and it's risky because, patients are exposed to other illness. They're exposed to antibiotics, which might have side effects. So if we can try to rationalize some of the experience of illness, and make it so that they don't need to rush into the emergency room just because they feel like their heart's racing.
So maybe giving them the tools the next time that happens.
For sure.
Take a couple deep breaths, take some time, sit on the couch, cuddle up with your dog, get a drink of water.
Exactly.
Those things to just calm the nervous system or to re-regulate the nervous system. What do you wish parents knew to ask medical professionals to help them collaborate more effectively?
I think there are times that parents actually want to feel like, I want to hear what they have to say.
Do you think that parents need to hear that from their physicians?
I do.
And their healthcare?
I think that parents want to.
So too.
I think they want to hear that it's okay that their child is suffering. Not that it's okay that they're suffering, but that their symptoms may be explainable by things other than illness, and instead it's related to circumstance and stress and
we need them. Right. We need the parent and we need the child to help give us data.
For sure.
Right? So instead of us just observing and coming up with this conclusion and plan, it's like we really need to work together.
Agreed.
To kind of piece through what's happening, when is it happening, how often is it happening, how frequently is it happening, when is it better, when is it worse.
And I think just saying things like, this sounds complicated.
I love that.
This sounds complicated. I'd like to understand this better.
I don't have all the answers either, right? Mm-hmm. Like we might have to spend some time working on this over the next several months, but this is a starting place.
Yeah.
I like that. So letting them know that it's complicated for you too.
Right.
Now it's not super clear cut.
Yes.
Okay. When you reflect on all of the systems of care, what is your biggest frustration? And is there anything that you're doing or that Oaklawn is doing to try to move past some of those frustrations?
I think that it feels as though some children and some families are sort of lost in the gaps of care.
Mm-hmm. So the gaps.
Yeah, the gaps between things. Like, yes, at school they might get some attention for their reading difficulties, but are we really delving into why they're struggling at home, at school, in the world at large? And same thing, I might see them, for an injury, but haven't had the chance to sit down and have a full well child check with these families in years. I see that so often, especially after COVID, that, it hasn't been a steady, continuous care environment, whether it's at school, at home, and at school or in the medical office. It's been more of a, sort of fragmented care. And so
And maybe like putting out a fire, it sounds like.
Yeah.
And the gaps, the frustrating part for me is because I see the gaps too. And the answer to that for me, I keep coming back to, we have to integrate systems. So the frustration is the gap. Right. The solution would ultimately be to integrate systems. And we know that systems change take so much time, right? So at Oaklawn, are you doing anything? I mean, I know that in your practice with your nurse practitioner and you're very well connected and you work very closely with the social worker. How are you trying to bridge those gaps?
I think Chrissy has gone back and earned her mental health nurse practitioner degree, and that we've built relationships with Sherry, our social worker, who specializes in mental illness and mental health care. That's a growing area. We also have in our offices care managers who can connect to all kinds of services, including social work, to really help patients of all ages navigate through some of those gaps that we were just speaking of.
Yeah, so it's trying to then navigate the access to services, the access to resources,
right,
and the barriers to getting that access. Yeah. And part of what we discussed earlier was that the resources might be there. People just don't know about them. Yeah. And it's not just that our patients and our families don't know about them. Sometimes our professionals don't know about the resources that are available across that discipline,
right?
And another discipline.
Yeah, and that's one of the reasons why I welcome, being involved here today in these conversations, is because I feel like we as an organization at Oaklawn have much to grow and learn from you here at Starr, and there's a lot of collaboration that we can continue to work on. And I see that collaboration, whether it's through mental health providers and schools and medical providers and then other community resources. I mean, there's a lot of growth to be had. And it does make me feel hopeful for what's to come.
We have these 10 steps to create a trauma-informed resilient school. And the same steps that you need to create a trauma-informed resilient school are many of the same steps to create a trauma-informed resilient primary care office or emergency department or, outpatient mental health clinic. But the one step in our 10 steps that I think is going to really, really come to life in the next couple of years is collaborating with community and families. And in that step, we begin to talk to educators about how they can reach their hand across the line to healthcare, mental health, law enforcement, parents, caregivers. And that often, historically, has been the hardest step for a lot of educators. And I think the work that needs to be done, the answer might be found in that step. Really bridging those gaps like you've identified, because that is so frustrating. And I think that every professional that is in contact with a family or a child has the same goal. So it's like, how can we all begin working in tandem just to make that come to fruition?
Yeah, I think that's a really key point.
Yeah. Okay, let's see. I think we have time for one more question. So it takes a village. So when you think about youth and young adults considering going into a care-focused profession, what would you say to them? So what do we need to know if we're going to be a child caring or a human caring practitioner?
I think it's some of what we were just talking about a few minutes ago, where a big piece of that is also learning to care for yourself, and learning how that you can't do everything yourself, but what teams to build and what collaborations to look for. And that's something that takes some maturity and some humility to do those things. But being able to care for yourself and being able to seek help and build partnerships will help any of those fields with longevity. Because I see, teacher friends of mine who are, struggling in the just progressing day to day in their schools, and nurses who are struggling and social workers. And so being able to find strength and longevity in those careers requires some of that.
Yeah. So self-care. Partnerships, collaborations, right? Look, those are all the things. And it's, I keep thinking as you're talking, it's like, we just have to break down the silos. It can't just be a hospital, a school, a family, a mental health clinic. It just we all have to work together. And I think we're getting somewhere, for our young people and people that are embarking on careers in these fields. I think it will be so important too for them to all have that same foundation of how stress and trauma impacts across all environments, right? It's like, this is so relevant for all of us in our homes, classrooms, exam rooms.
I agree.
So as you look to the future, what are you excited to learn more about?
I have a lot of excitement about learning just different ways to lead and guide my colleagues and other community members, how to work together, how to be strong through challenges. I really see that some of the next stages of my career will be in that leadership and guidance, and I'm looking forward to that.
Yeah, that ties really into our theory of change at Starr. So at Starr, our theory of change is that if we can get as many caring adults as possible to be more aware of trauma and more aware of how to promote and foster resilience, then the well-being of all children and families and communities is going to increase. So it's like the more we can each learn, then we all go out and we make an impact.
I like that.
Yeah.
Yeah, that sounds very sensible. Very, very strong approach.
Yeah. Dr. Liston, we cannot thank you enough for joining us today and for you sharing your constant curiosity with us. Oaklawn and your community are so fortunate to have you.
Thank you very much. I appreciated the time.
Thank you for joining us. Please subscribe wherever you listen to podcasts. Don't forget so that you don't miss out on any of our upcoming content.